Okay, welcome and thank you for joining us today. We are going to be talking about building a school-based mental health consortium from referral to funding. So we're hoping to go beyond, typically we, just talk about referral processes and forms and what that looks like, but to really spend a good portion of our presentation today on funding and some different options that you potentially could be using in your district. So I am Tracy Kelz, Director of Student Services. I am currently in my 6th year within the Marshfield School District. I have a background as a school psychologist, and areas of interest are equitable services for all students and behavior. I started working on the consortium during the 2017-18 school year. And then, gradually we've been adding in more and more people. We did add in a mental health coordinator and navigator, Joann, who I'll let her introduce herself.
My name is Joann Greenlee. I've been with the district for the past 19 years, primarily as a school social worker. My background is in clinical social work, so I was a therapist for about 10 years, working with children primarily. My interest is children's mental health, empowering families, and improving access. And I was hired as the navigator last year, so this is my 2nd year as the navigator.
And just forgive us, we're trying to figure out the sound here a little bit as well. We're in the same room, so we have a little bit of echoing going on, so just sorry about that. So first of all, our district demographics. These are from the 2019-20 school year. And you can see that our district is about 4,000 students. Our female to male ratios are quite comparable with what you see for the state percentages. When you look at our ethnicity, we do tend to be a primarily Caucasian school district. However, we definitely are expanding diversity. Every year we are seeing increases. But again, you can do some comparisons here to state percentages as well. We do have a relatively high populations of students and families that have needs related to needing resources. Our disability percentages are slightly lower than the state, but that's an area that we're always looking to hopefully decrease with solid interventions as well. We did want to add a slide related to our district student service staffing. This is something that our district has been really working on, I would say probably the past 4 years in particular, trying to increase our student service staffing. Right now, our school counselors, we have 4 at the elementary who service 5 schools. So we do have 1 counselor that's split between 2 buildings. Otherwise, the rest have full-time counselors 5 days a week. Our middle school currently has 1 school counselor who's very busy. Our high school has 4. We did just recently add 1 who is a 0.5 AODA coordinator. So that's something that we've been working towards for quite a while. And she is the district AODA coordinator. School psychologists, our elementary has 3.5. One of the school psychs is also a 4K early childhood school psychologist. So they spend 2 days a week working with the 4K and early childhood population and staff. And then one of our school psychologists is also our MTSS coordinator. Our middle school has a 0.5, which is split between the elementary. And then our high school has 1 school psychologist who's also split between the alt school. We have 2 district social workers, and then we have 1 mental health coordinator who used to be, Joann, actually, who's presenting with me today, used to be one of our district social workers and then did transition into that mental health coordinator role last year. We have 2 district school nurses, and then every building also has a health assistant. So as far as starting the consortium, it really was a long process. It wasn't something that we just put together and did quickly, within 1 school year or over a summer. And I just think it's really important to stress that we definitely did it within phases. And the first phase was really all about learning and planning. So I'm just going to walk through timelines. I know there's a lot of words on here, but at the same time, we felt it was important that you had a little bit of a roadmap to see, you know, not only what we did, but the years as well. So you could kind of see how long that process did take. So the first recommendation that we would make is to really identify the why. So, you know, you need to know what you're doing the work for, why you're doing it, and to really be basing those decisions on data. So for example, when we started this process, we spent a lot of time collecting data related to mental health visits and worked very closely with our student service team on defining what a mental health visit was. And so we logged all of those in Skyward. We also collected data on how many students we're seeing outside community mental health providers. Our district did not have a referral pathway to services. At the time we started this, we did have community providers providing services under MOUs within the district, but we were not allowed to refer directly to them. If families were interested, we had a resource manual that we were allowed to give them, but we weren't necessarily allowed to say, you know, so-and-so providers in the building, we'd like to refer you to them. So our student service staff felt that was something very important that we wanted to change. We wanted a clear and consistent process with a variety of options that we could use. So we wanted to have designated community providers who also shared our vision and goals. So really important that you spend a lot of time in the beginning identifying, you know, what your district vision and goals are, but also aligning those to what your community partners' visions and goals are. Because if you want to have a successful partnership, you really need to have those shared vision and goals. So the two main areas that we focused on were collaboration and communication as a mental health team, and then provide all referred students access to services regardless of their ability to pay. We did develop a manual for our consortium, which you'll have a link to. The full manual, I'll be showing you a few sections of it a little bit later. But one part of that was titled our stakeholder commitments and guidelines. And so it really clearly identified what the school district would do and what the agency provider would do. So that was something that we collaborated on with our consortium partners in developing, you know, what we all agreed to do. And that was kind of the process for that. So as far as getting started, you know, the very first thing that we did is we started looking at, well, what are other districts doing? Because really, you know, you don't want to create the wheel if you don't have to. It's a lot easier to try to tweak a wheel. So, you know, we started back in January of 2018 and just set up some visits and phone calls with some area school districts that we knew had consortiums running. One of them was the Wausau School District, which they are part of the Marathon County Consortium. And then the other one was the Madison School District. So at the time, our MTSS coordinator and I did do a visit to the Wausau School District, and we had a couple of phone calls. And we had a couple of phone calls with the Madison School District as well, and just got some ideas for what they were doing, and kind of looked at, you know, how we could potentially implement those ideas in our district. In April of 2018, we had a community group called Macy that had a mental health work group, and they had a presentation by the Marathon County Consortium leaders. So, you know, we had myself, our district MTSS coordinator, and our two social workers all attended that session and learned about how the Marathon County Consortium was formed. They had a really, really good presentation that gave kind of the timelines, as well as, you know, some tips and tricks and different things that worked well for them. So in May of 2018, you know, we started having more of those focused discussions about how to actually start this process. And, you know, our first idea was, well, let's start a Wood County consortium. You know, Marathon County has one, let's start one here. We realized very, very quickly that we were biting off way more than we could chew at that point. You know, when Marathon County started their consortium, it was started more by the group of providers, not a specific school district, which was different than how we were trying to proceed where we were. So, you know, we had a lot of discussions about that and thought, you know, maybe someday we would look at doing a Wood County consortium, but for now, We want this to be very manageable, and we want to make sure that we do it the best we can. So we really scaled back our plans and decided to start with just our district, the Marshfield School District. So between May, June, July 2018, one thing that I recognized very quickly was, as the Director of Student Services, I was having a really hard time finding the time in my schedule to lead this completely. And, I had the social workers helping me. I had our MTSS coordinator helping me, but they also had full-time jobs. And so it kind of felt like we had little pieces going everywhere, and it was just difficult. So we did recognize the need to have an actual facilitator for this process, similar to what Marathon County's model had, which was a county health department public health educator. So we started, we did talk to that person and got some ideas, and we started researching some potential grant options. So we did decide on, it was called the HWPP Change Incubator Fund, and that was through the Healthier Wisconsin Partnership Program, and it's a capacity building grant. And that was something that it was for $10,000, and it helped us secure a facilitator. So we did bring that to our board committee and discussed basically our outline of the grant, establishing the need, but then also building sustainability, because we realized that with grant funding, it's not something that you're going to have forever. It's just something to get you started. So discussing how we would continue that moving forward. We also had some conversations about possible facilitators. We knew that we needed somebody that had a lot of knowledge in this area, because although we had a lot of knowledge in the school realm, we didn't necessarily have a lot of knowledge in the private practice realm. So we started, seeking out different people that might fit that role. October 2018, we had a planning meeting where we drafted letters to area providers just to see, who may be interested. Because before we did a lot of this work much further, we needed to make sure that we had providers within our community that even wanted to start these conversations. So we did send those out to providers in October. In November of 2018, we submitted our grant and again came back, updated our board committee on our progress. In December of 2018, that should say 18, we did receive a $10,000 grant and secured a facilitator who we were extremely lucky to find. His name is Chris Crow, who is the director and principal of North Star Academy Charter School and also the chair of expanding school-based mental health in Wisconsin. So he came with a wealth of knowledge. He was really able to, kind of guide our team as far as what are some of the first steps, and to work with us throughout that process. So from there, we would go to what we're calling phase 2, and this is really where a bulk of the work was done. There was a lot of work done during this period. So this is strategic planning and development. So our grant funds were able to be used and utilized in January of 2019. So that's when we began work with our facilitator. We sat down with Chris and really talked through timelines because our funds for the facilitator were only able to be expended through July of 2019. So we had a very short window to get a lot of work done. So we worked with Chris to develop a timeline, objectives, as far as that grant funding. We also discussed briefly the DPI mental health grant, which we knew was going to be coming out a little bit later in the year for the possibility of a coordinator navigator position. In January and February of 2019, we had a few focus groups, and really the intent of those was just to get feedback on what our mental health needs actually were. We had 2 different groups. One was our student service team, and then the other one, we brought in some high school students, parents, and community group members. In February of 2019, we held a presentation and Q&A session for community partners that we had sent the letters to back in the fall who were interested in joining the consortium. So during this presentation, we discussed our need, which we had established from our focus groups. We discussed our objectives and goals and really what our vision was for this consortium. We also had the Edgar School District and the Marathon County Public Health Educator present on the work that they did with Marathon County, so they could kind of show the process from start to finish as a really good example. And then they were also able to help us answer some questions that the community members had. In March of 2019, our student service team worked together to draft a referral pathway, and provider capacity calls were completed. So I'll be showing you some pages from our manual that walks you through that referral pathway process in just a couple minutes. The provider capacity calls were basically, just calling them and asking just that, what is your capacity? How many providers do you have available? How much time do you have? Do you prefer elementary? Do you prefer secondary? Just trying to lay the groundwork for how we would be scheduling those in the buildings. April of 2019, we completed some draft MOUs for our consortium members. We really used our basis off of the MOUs that we had established already, that we had been using, and we just made some simple tweaks that aligned with our stakeholder commitments. We also applied for the DPI mental health grant in April of 2019, specifically for mental health coordinator and navigator. Also in April, our consortium team met and we presented our strategic action plan, commitments and guidelines, and that again is all going to be in the manual, which you'll be able to see later. And then we also discussed possible funding sources for students with financial barriers. That was something that from the very beginning, all of us agreed that we really wanted this to be about all students that were referred having the ability to receive services regardless of their ability to pay. So we all really shared that vision. Right when we started, we weren't exactly sure how that was going to happen, but we were very committed to continuing to look at that and plan for that throughout this entire process. Also in April, it's a very busy month. We did another board committee update on our progress. We reviewed the MOUs with the board committee for approval. And then they did approve the MOUs in August, the actual MOUs. And then providers reviewed and signed, returned. That way everything was set to go when school started in September. So it's really important, when you start looking at MOUs and agreements and things like that, that you really plan out a few months to make sure that you're allowing for that time. If it needs to go to your board, it needs to be approved, then it needs to go to the providers, they need to get it approved. And then you have to have everything back. Just make sure you give yourself adequate time for that. May of 2019, we just had a small team work on data collection. I think that was myself and the social workers and our MTSS coordinator. How are we going to collect data? What are we going to collect? When are we going to collect it? Because we want to make sure that what we're doing is effective. Our consortium team also met in May, and we reviewed drafts of the referral pathway, the suggested MOUs, discussed building assignments. June of 2019, we had a very preliminary meeting with our Area United Way to have some discussions about potential future funding options. So again, throughout this process, we knew eventually that we would want to try to establish a pot of money that we could draw from for students that weren't able to pay for services. So that meeting really wasn't about securing anything at that point. It was more just kind of laying the seeds and having an initial conversation about, is this even an option? How would this look? What would we do? And so they did alert us to some potential grant funds at that time. July of 2019, another consortium team meeting where we reviewed the finalized manual, our MOUs for signatures at that time and building assignments. And we also were notified in July, which we're very grateful and happy that we did receive the DPI mental health grant to hire a mental health coordinator navigator. So that was really important because that was right around the time where our funding was going to be done with Chris for our facilitator. So it was just a really nice transition. The stars kind of aligned where we were able to transition that role from the facilitator to bringing on that mental health coordinator and navigator. All right, so phase 3 is our final phase, which we're in now, implementation and review. So August and September of 2019, we did transition Joann, who's going to be presenting shortly, from her role as a district social worker to our mental health coordinator and navigator. So she really at that point took on much more of a leadership role within the consortium. Like I said, as the director, it was getting harder and harder the deeper we got into this for me to be able to be the lead on all of that. So her and I work very closely together, but she really is the lead in this process now, where she's planning the meetings and the agendas, leading the meetings, working very closely to connect providers to referred clients, a lot of times helping families, answering questions, helping them navigate and complete forms. If families haven't completed forms, checking in with them. So really trying to reduce those barriers, just a lot of logistics and problem solving. And then Joann and I do meet typically on a weekly basis. And, just if there's any updates or anything that I need to know, or if she has questions, or just back and forth. So we're pretty connected throughout this process. September of 2019, the mental health navigator, Joann, and I met with each of the buildings, principals and student service teams to just walk them through the manual and the process. It wasn't anything that was new to our student service team members because they had helped develop the process, but we just wanted to, kind of deliver the final product, which was this manual, and make sure that everybody was on the same page. I think making sure that communication is critical to this entire process, making sure everybody understands the referral process, what to do, where to go if they have questions or if there's road bumps. October of 2019, we met with the Community Foundation regarding fiscal agent possibility. So, what we discovered throughout this process is, yes, there's grant money, yes, there's funds, but then you need to decide, who's going to manage that money. Is it going to be your district doing it? Is it going to be some outside agency? And at this point, the direction that we're hoping to go someday is to move more towards, a small, maybe central Wisconsin, Wood County consortium. And so for us, it was really important that it wasn't just the school district managing the funds. And so that's why we chose to seek the Community Foundation as a fiscal agent. That is a short-term solution. It's not something that we'll be able to use forever. So in November of 2019, Joann did complete an application for United Way, where we asked for a pretty substantial amount of money to establish the student sponsorship fund, which would be for students that, families that have those high deductibles, co-pays, or no insurance. So, that's a huge barrier for some families when they have to choose between mental health services or groceries or, things like that. So we just wanted to try to remove that barrier. In February of 2020, we did meet with the Community Foundation again regarding fiscal agent steps, and it was approved. So we were able to move forward with that. And we did receive the United Way funding in March of 2020. So Joann is going to go into much more specifics. We're hoping to spend a good majority of her presentation actually on the funding part, because we know that everybody's very interested in that. So I will leave the rest of that to her. Currently, our fund is established and active, and we did put together a review committee, which involves myself and then two community members. We meet monthly to review applications that have all identifying information redacted. And Joann, again, like I said, will discuss this process in greater detail, and will actually walk us through an application to see, how our team reviews that. And then we do continue to meet with providers on a monthly basis to address issues and problem solve. Future, our goal is eventually, like I said earlier, is to establish a consortium board that will become their own fiscal agent. Then at that point, that would transition from the community foundation over to this board, which would likely involve, maybe Joann and I, and, potentially if there's other districts brought in, maybe representation from them, community representation, possibly. So that's something that's, out there for a few years, but something that we would like to work towards. And then lastly, I think Joann might talk about this a little bit, but we're looking to expand to add psychoeducational groups as well. I know that we're in the process of applying for a second grant that would establish a very small fund that we could use specifically for providers to provide that additional service to students. All right, I know, I feel like we're running out of time here, so I'm probably going to go through this pretty quickly. It is in the manual that you'll have a copy to, so I'll just maybe highlight some of the important points here. So this is part of our program guide and strategic action plan. So our mental health pathways, this was developed by our student service team with input from our consortium providers as well. So, how does this process work, the referral process in our district? So, it all starts with data. The data is going to prompt a referral to a building student service team. So our district chose not to have it just be an open-ended referral where anybody could refer. We kind of wanted to funnel it a little bit to make sure that we were meeting the needs of the students that we felt had the greatest need first. So all referrals go through our student service team, which includes, social workers, counselors, psychologists, nurses, principals, mental health navigator, and sometimes the mental health providers themselves can be part of those teams. So they're reviewing the data, and then really there's a couple different options that team could choose. And it's not an either or. It's not like, just one option and then not the rest. Sometimes it might be that way, but it's likely more a combination of some options. So option one would be continue classroom school-wide interventions. And this kind of follows that whole MTSS process where you think about, has the student received some evidence-based interventions? Is there anything else that we can do within the classroom or, providing our interventions before we look to more restrictive or intensive type of intervention? So option two would be school mental health providers, which would include our social workers, counselors, psychologists. And I'm not going to go through these. You'll be able to see those in the manual. Those are just typical responsibilities. Option three would be your community mental health providers in school services. And then option four would be the community mental health providers in community. So this in-school process is really, for students that have additional barriers where we feel like they're not able to access the community services. And then data is collected to determine student outcomes throughout this process. So this option three, when we go on to the next slide, this flow chart is really just expanding on what that option three process looks like. So we chose to have our point of contact be our school counselor in each building. They may, however, delegate some of those logistical tasks to others in the building as appropriate. So the point of contact, which is the school counselor, completes the school mental health referral form, which is on the next page. I'll show you that very quickly when we're done with this. They complete that with the student service team during that meeting, and then they contact the guardian to review and collect information. So actually, I think maybe I will just flip to that really quick. It might be easier. So this is our actual mental health referral form that the school counselor is going to be completing. So it gives, all your basic information that you need here. It's giving information related to reasons for referral, which is part of the data that we do collect, as well as insurance coverage and barriers, which again is information that Joann is collecting on a regular basis and reporting back to the consortium as far as what barriers are and where the majority of referrals are coming from. So if the guardian provides consent to refer, which is important to note, the counselor will scan and email that completed that form and provide it to the mental health navigator and the community provider. The counselor will then keep a copy of the form on file as well and mail a copy to the guardians. So everybody's really informed in that process early on as far as what's happening. Upon receipt of the referral form, so this is where the responsibility tends to shift over to the community provider now. They will be contacting the guardians to schedule that intake. And then they use all of their own intake packet forms because that might be different for each of your providers. And we chose not to have any type of consistent form because then that involves them redoing what they have. And that was just, nobody wanted to do it that way, which completely makes sense. Each provider's release of information form also is included in the packet, and then they are scanning and emailing that back to our counselors after they get the signatures. If the guardian refuses to provide this release of information, the provider at that point is going to recommend the family for community-based services. And I know that might sound a little harsh, but that was really, really, central to our process, was making sure that we're all on the same page and that there's a high level of collaboration and communication. So we felt very, very strongly, when I say we, I mean our providers and our schools, so our consortium, that we definitely needed to have that in order to make this process work the way we intended. If the provider was not able to contact the guardians, then that's where Joann might step in or the counselor step in and try to help with that contact. Once the intake process is completed, the provider will be working with the counselor and really looking at the calendar and getting all of that set up. One more important note here, if the guardian does not provide consent, again, to refer them to the community mental health provider. And then other options, which are back on that previous slide. And there's a referral form. We went through that. So at this point, I'm going to turn it over to Joann, who's going to talk much, much more specifically about some of the things that I just kind of presented on a surface level.
I'm Joann Greenlee. I'm going to talk a little bit more about the specifics of the consortium. First part, we're just going to really talk about how it works. So assigning therapists, the student services team role, barriers to service, and then some of the logistics of setting up services. That first year, having the therapists in school, we had to figure out what schools needed what and what the capacity of the therapists were. So we started with that. As Tracy said, we got information about what each therapy agency felt they could, what amount of time they could give us and what their specialties were, which level they wanted to work. And then we looked at the history of needs in each of our buildings and built a grid and assigned workers and agencies into each of those grids based on what previous needs were. I will say we were not perfect. We made some miscalculations and had to adjust partway through the year. Our country school, we had only had a half day of services without sort of recognizing that they had significantly more barriers in terms of scheduling and transportation than any other school. And so they filled up relatively quickly. We ended up expanding to more than a full day of services out there that we just had not anticipated. During our second year, the beginning of this year, we allowed the therapists to work more closely with the buildings. They were already, each agency was already assigned a building. And so they worked more closely with the counselors and the school principals to negotiate their own schedule. So we were a little bit more hands-off and let each building and agency decide how they wanted to schedule. Now, student services teams. Tracy mentioned them several times. They've been running in our building for quite a number of years, especially since the school social workers became district-wide social workers. Although they were in place in several buildings even before that, sometimes called a child study team or different things like that. As Tracy mentioned, it's a school counselor, school social worker, school psychologist, principals. At different levels, it looks just a little different. At the middle school level, the school resource officer also participates in the student services team. At the high school, because we have 4 counselors, the team is split up. And so there's consultation with each of the counselors individually with the principal coming in as needed. So each level looks just a little bit different. All of the teams, however, consult regarding struggling students. So they really talk about all kinds of needs, not only mental health needs, although that's a big focus. They look at academic needs. They look at family needs, as well as the mental health concerns. And the team is meant to be a problem-solving team and a place where staff can sort of assign follow-up roles and figure out what is needed, as well as do those referrals that are necessary. Again, they're using that referral pathway that we talked about and really looking at what are the current, current barriers and how do we get around some of those barriers. If a consortium referral is necessary, they make that referral. The consortium really is primarily focused on families and students who have some barriers to service. They can't easily access those outpatient services. And so that is the main focus for that kind of referral. So we want to do just a small activity, which now that we're not live, I'd like you to take just a second to pause the video and think about, for you, what are the barriers that you believe families have related to mental health services? And then, excuse me, how have you traditionally overcome some of those barriers? And if you just pause for a second and think about those things, we're going to talk about them next. So as you saw on the referral, we have some stated barriers on the referral. Financial barriers being one of them. Scheduling and transportation are our largest barriers by far. We've had the barrier of having some wait lists in the communities, so families have a long wait before they can get into services. Sometimes previous counseling has not been successful, and so there's hesitancy, but then the family's more willing to try it in the school because that's a familiar setting for the student. We do have some student refusal that's difficult to get around, as well as what we would call the stigma associated with mental health treatment. And that really has to do with families or students not wanting to be involved in those services because of that stigma or feeling like that is a strike against them or a weakness. There's also some underlying barriers that are not articulated the same way on our referral form, but still really important, which is difficult to engage parents or lack of follow through from parents, which sometimes is because of simple things being overwhelmed, long works hours, those kinds of things, but as well some of the stigma related to mental health. And sometimes the barrier has to do with needing to have and wanting to have that close contact with the therapist and needing to consult closely with them. So the barrier really would be not operating in silos, but being able to work very closely with the therapist, and the consortium works really well for that. Getting around some of these barriers, I don't have a separate slide for that, but I wanted to talk about it a little bit. Pre-COVID, a thing like scheduling and transportation, obviously if things happened at school, that barrier is reduced. However, families still need to do an intake with the agency. And so we would sometimes provide actual transportation to an intake appointment. We don't do that now, but we can set them up with MTM or cab vouchers. And we try to be creative on how they can get that intake done, and it can be virtual now, so that helps that. The student, student refusal, that really comes down to that relationship with the school counselor and talking through with the student what benefit therapy could have. And so we count heavily on the relationships that we already have within our buildings to try to overcome that particular barrier. I should say we're going to talk about the financial barrier much more extensively. So I'll get to that in just a little bit. I want to talk a little bit about the actual logistics. Tracy reviewed them a bit when she talked about the referral pathways. That takes care of a lot of this information, but it starts with a consultation with a student services team. If it's appropriate, a referral is made either by the counselor or the social worker, sort of whoever takes the lead in the team. And again, that's based on who has a relationship with the family already. We almost always go with that relationship piece so that families aren't getting confused with lots of people involved in their life, but who is their person at school. We get that parent permission. If the student's over 14, we also get the student permission. If they're under 14, we still want their consent, but we don't get that the same formal way as we do for over 14. The referral is sent to myself, usually the agency. We do have some cases where there's more than one agency in a school, such as our high school. And so then the navigator, myself, gets those referrals and they get assigned out. Sometimes there's also challenges, which we're going to talk about in the next slide, that cause it not to be quite as straightforward. And so I help negotiate some of those difficulties. Again, the therapist contacts the parents directly after they get the referral. They complete their own intake paperwork. They set up their appointments. All of that, the parent must participate. And then I'm notified if there's some additional obstacles, which does happen more frequently than we would like, where a therapist can't get a hold of a parent. And so then I will coordinate the two of them getting together in some sort of way, or making sure the parent calls the therapy agency. I want to make it pretty clear that our very first funding option is that the agency bills through insurance. And I'll have a financial needs slide in a little bit so you can see sort of the split up having to do with who has insurance and who doesn't so far. But that is the main mechanism. We're not considering these free services, but we do have mechanisms for financial assistance as well. And then the therapist really works out with the building, making sure that there's scheduled and room availability in each of the buildings, as well as they do consulting with the school counselor to get additional information and to do ongoing consulting for the student. And then I do follow up, whatever needs to be done. As Tracy mentioned, I will sometimes, get signatures. Sometimes I'll make phone calls. Sometimes I'll carry applications to an agency. Whatever is needed, I will do that case management and follow through. So there are some process barriers, that's what I would call them, in terms of some of those challenges that I mentioned after the referral has been made. And I just listed a handful out. I'm not going to go through every single one, but things can get complicated. When a child transfers from one building to another, there's issues having to do with if they saw a therapist one year, who are they seeing this year, if there's a different provider in that building. If you have siblings that are both referred and one has one provider in their building and the other has a different provider in their building, how do you figure out, because really for the family, it would be best to have one provider, and how do you work some of those things out? How do you work it out if they want a male or female provider and that's not in the building? And I'm not going to give all of the exact answers for all of these because there isn't an exact answer. What it is a good amount of flexibility, excuse me, and a good amount of working together in cooperation and sometimes compromise, with that really big value and goal in our head that we want to get services for kids. We want them to keep getting services once they've gotten them. So having to do with providing services is really our end goal with those. Okay, so this financial barrier, access to all, that's sort of what we call it. We'll talk briefly about the fiscal agency, which Tracy already mentioned a bit, how we determined the need for some monies. our United Way grant, and then how we have dispersed those monies, or how, what our process is. So first, we did pursue fiscal agency with the Marshfield Area Community Foundation. This worked really well because our United Way and our Marshfield Area Community Foundation have a really close relationship. They work very closely together. This was a really good match for us. The Community Foundation already manages scholarships and grants and startup assistance for nonprofits, so it was a super good match. They can take in donations and they can disperse out payments. So it worked really well for us, and we kept it very simple. So it's not complicated for them or for us. And as Tracy mentioned, the purpose really had to do with having the budget and accounting separate from the school district. That just makes things simpler, but it also will allow the consortium to expand to other schools in the future without it being mucky. So when looking at the financial need that we had in our consortium during this first year, so we looked at where the funding for therapy was coming from. Most of our families are Badger Care, and so that makes it super easy. We have a good amount that have private insurance, and then some who can't pay because their deductible's too high, or they have no insurance. We have a couple unknown, and that's primarily because we had that referral, but then the parents backed out of it. And so that additional insurance information was never gained. That's why that's unknown. But looking at this during the first year, it sort of vacillated throughout the year. We had anywhere from 10 to 20% of families who declined services because they did not have the ability to pay. Now, I will say during the first year, before we had any additional funding, we got around some of that creatively. We were able to talk to our therapists, and some of them would take on some pro bono cases. So that was very helpful. So we had some of the no insurance, especially, who were able to be seen because we had lovely therapists who were willing to do some pro bono work, as well as one of the agencies we work with, Children's Wisconsin, does have their own financial assistance program. And so we would help families get connected with that if that was appropriate for them. That worked really well for low-income families. It doesn't work well for higher income families who have a high deductible that they can't pay. So we still had some people hanging out that couldn't get services or refused services because they didn't want to deal with a high bill. So as Tracy mentioned, we were looking at funding from United Way. And one of the United Way's goals is to have access to healthcare. And that matched us perfectly. So we were able to have that shared goal, which made us a good match and fit really well into their application process. We proposed to them that we get some monies and funds to pay for individual therapy for families and students who either had no insurance, a high deductible, or what we would call underinsured. And what I mean by that is families who have insurance, health insurance, that either doesn't pay for mental health services or greatly limits the number of visits. Say you can have 5 or 6 visits, mental health services. Or sometimes we've dealt with in-network and out-of-network, where an insurance agency does not have any Marshfield area agencies that take their insurance. So we've dealt with those issues. This is the formula that we based it on. We really looked at about 20% of our students needing assistance. At that point, we had a capacity for about 100 students in the consortium based on the schedule that we had and the availability of therapists. And so we were thinking, okay, let's ask for money to pay for about 20 students who may need funding. And through discussion, we sort of talked about we had to put some limits on it. We couldn't pay necessarily into infinity. So what would make sense? We made a compromise of 15 weeks, which is a little bit less than 1 semester here in Marshfield, which is 18 weeks. And we figured with getting something up and going, it pays for about 1 semester of therapy. Our agencies agreed on a rate of $120 per session. And so we asked for $36,000 from United Way and they gave us 26.5. So we were pretty pleased about that. So as we were asking for the money, we realized we needed to have a mechanism for giving out the money and determining who was going to get the money. We wanted to be good stewards of the money. So it wasn't just if you ask, you get. We wanted there to be an application. We had an underlying assumption that we wanted to fund as many students as possible that were in need. And we based it off sort of a community care model. So I looked at multiple applications for community care that looked at not just the financials, but also some other extenuating circumstances. And we built an application based on that, which I'll be showing you shortly. We have 4 ways to qualify. We have some preemptive eligibility, which this is very common in a community care to have some preemptive qualifications. One is free and reduced lunch, because free and reduced lunch is about 200% of the federal poverty level. We decided that our families designated as homeless could be a preemptive eligibility given the struggles that our homeless families have. And because we're a trauma-informed school, we really talked about having a parent incarcerated and that could be a preemptive qualification. We also looked at whether medical obligations were more than 20% of somebody's income, and with high deductibles and high copays and such, that can easily happen, as well as if there's medical debt. Then we looked at not just how much money each person's bringing into their household, but what their obligations and expenses are to help us with that determination. And then there's also extenuating circumstances, because we know sometimes things get complicated, and we wanted to be able to look at those complications. So we established a committee. As Tracy indicated, the committee is 2 outside agency staff. They're non-therapy agencies. We didn't want there to be a conflict. And then 1 school staff, which is Tracy. I prepare materials and facilitate the meeting, but I'm not part of the decision making. And we meet monthly to review the applications. So here is the application for our financial sponsorship. We called it a sponsorship. And I do want to say that part of our process also has to do with wanting to be very careful, having to do with insurance issues. So when we talk about the payout, I'll explain that a little bit. The applications are completed by the families and usually a student services staff, and most frequently that's going to be me, in that I'm very familiar with it, and it's a good way to make sure I understand the family dynamics and extenuating circumstances as I bring them to the committee. We redact all the personal information when it goes to the committee, so that they really just have the numbers and some basic information. The applications are due by mid-month, and we review them the 3rd week of the month, so that we're only looking at them once a month, not sort of as they come in. And that's just our way to manage it. The application really has what I would think of as 5 sections. It has a section here at the beginning that is related to just logistics, family information. This section here that's in the light gray is our preemptive criteria. So if they answer a yes to any of these, then we know we don't really need to go further in the application. They can be done because we know that is going to be qualify them. We have a section for extenuating circumstances, and I'm going to tell you there's not nearly enough lines for people who need this section. In the example I give you, we have an add-on so that you can attach sheets to this. And then we look at assets. How much do they have in their savings account? Do they have some flex spending or HRAs to help with those expenses? So that's the basic application. I do have a worksheet that I do that helps me figure out some of these numbers. I didn't include that right now, but it just helps me calculate them, like the medical cost percentage and household income versus expenses and that kind of stuff. It just makes it easier for me, but that's one of the things we also have. So let me tell you a little bit about the sponsorship payment process. After an application is approved, again, this goes back to that insurance issue. We are not being billed directly as a consortium. Insurance always takes precedent. If a family is approved, they can provide to us either their bill or their explanation of benefits, and then the consortium will make payment directly to the mental health provider, and the family will be invoiced having to do with that, so they know exactly what's been paid. So I send a monthly request to the community foundation. And I assign students numbers so they know, so I can track who the bill is for, but the foundation doesn't know who the bill's for. They just know the dollar amount that's supposed to go to the mental health agency. I then send the agency information about who they're going to get payment on, so they can apply the bill appropriately. And I send documentation to the parents so that they know that their bill has been paid. Our sponsorship will go back 4 sessions prior to application if that's appropriate. Again, we pay no more than $120 per session, even if the charge is greater, although our agencies have been really great in terms of negotiating with parents when they're able to do that. And right now our sponsorship is only paying for a total of 15 sessions. If more is needed, then they need to revise their application, and we need a supporting document from the therapist having to do with the need for continued therapy. We haven't come across that yet. So we have not spent much of our money because of COVID primarily, and the shutdown that we had. We have gone through several applications, and we anticipate spending some of that money soon. But the United Way grants for next year are due now. So we looked at, okay, what do we want in year 2? And really looked at what Tracy talked about in terms of expanding our mental health consortium and how do we do that to be fiscally responsible. We talked about some therapist-led psychoeducational groups, and this is what we proposed, looking at the 21-22 school year. And of course, this is all contingent on getting back, well, it's not contingent on, we will take into consideration what COVID restrictions we have, and this may be altered based on that. But right now we anticipate doing some groups in the fall at our middle school and at our alternative high school. Middle school, because our youth risk behavior survey saw a great need at middle school for mental health services, and our alternative school because that happens to be a high risk group of students, and so that makes sense, as well as their schedule is much more flexible in terms of being able to coordinate a group. And then in the winter, we'll also add a group at the high school. So we're looking at 5 psychoeducational groups being run by therapists, looking at probably a cognitive-based group, like a DBT group or some other kind of skills group that will complement therapy. And we're really looking at this to for 3 different student populations. One would be students who just need that skill building and don't have a high need for therapy, but something greater than what our counselors at school may be able to provide. Students who probably need therapy, but their parents are being resistant, and there may be other barriers, primarily that stigma barrier, but they would be willing to participate in a skills group, which we think would be great. So that psychoeducational group could be very beneficial for them. And the third group are people who are students who are in therapy, and we believe that the psychoeducational group could increase their progress and really boost therapy to make it more efficient. So those are the students that we're looking for to do this group. And we are simply asking for $5,000 from United Way. We want to guard against using the current pot that we have for individual therapy. We want to expand services, and we truly want to continue to be a partner with United Way. It's a great relationship, so we want to continue that. That is it for the logistics of our consortium. Tracy's going to take back over and talk about some key components and our contact information.
Okay, So some of the key components and tips for building a successful consortium that we found and would like to share with you, one of the first things I think really is just to start small. So, try not to take on more work than you have resources. So again, tweak the wheel, don't create the wheel, look to what other districts are doing. You're not going to find something that one district is doing that you can just say, we're going to adopt that. Likely, you're probably gonna have to look at a few and then take little bits and pieces from what others are doing and make it your own. Really take the time to plan before you even get started. I think that's one of the things Joann and I were just kind of laughing about as we were preparing this presentation is we always felt like, boy, things are just falling into place. And, it almost seems easy at times. But when we went back and created this presentation and started looking at timelines and all the different things we did, it was not an easy process. But I think that it felt that way at times because we were very methodical. We took small steps and we were always planning ahead throughout the entire process. So with that, develop your timeline, your phases, your strategic action plans with checkpoints. So you're always able to figure out where you've been, where you are, and where you're going. Bring in key stakeholders at key moments. For example, make sure that you're involving those community mental health providers right away to make sure that you're getting that buy-in, that you're all on the same page, and that you have adequate coverage. Share progress with key stakeholders at regular intervals. So this would be with your staff, your board of education, your partners. Make sure that everybody's on the same page, as you move through the different phases. I would highly recommend researching and applying for grants throughout the process. Without grant funding, I don't know that we would have gotten as far as we got, maybe even as quickly as we got. So always be looking ahead to, how are you going to pay for what you're trying to do? Are there grants available? And then also probably most importantly, how do you sustain that work after the grant money is expended? Once established, have regular meetings the first year within your consortium. Even if you don't feel like you need to meet, I would highly recommend at least one time a month, possibly even more when you first get started, just to make sure that things are running smoothly. Highly consider establishing a need for a mental health navigator early on in the process, or if you've started the process, even then, and that's talking with your administrators, your board, really how that type of a position and the work that they do is really key, I think. And then again, always thinking 6 months to a year ahead. That's really important as well. So again, some of the key components: mental health navigator coordinator job description, or some districts aren't able to do that. Making sure that you have dedicated time, and that's really in bold because, if you're going to have this be part of someone else's roles or part of multiple people's roles, make sure that those roles are very, very clearly defined and that they actually have time to work on it. Because I think that was one of the things, Joann, that you would agree we found early on was it was getting to be really rough, for me to do some of it, the MTSS coordinator, the social workers. And so, eventually having somebody who really is coordinating that was essential to the success. Referral pathway process and referral forms is key. Strategic action plan with checkpoints, that buy-in and support from key stakeholders. And then also having very strong relationships with your area community mental health providers and community in general. Okay, brings us to our last slide, our contact information. Definitely Joann and I would love to hear from you. If you have any additional comments or questions, please feel free to reach out to us. So thank you very much. We hope that you found this presentation useful.